Alzheimer's is also a disease that's very personal for me. My mother died from Alzheimer's, and unfortunately, my wife is suffering with Alzheimer's. It looks like there's about a 10 to 15 year window prior to the onset of Alzheimer's where we can pick up the beginnings of Alzheimer's and intervene in such a way that you ultimately won't get the disease. And I think within 5 years, we're going to have this as a chronic illness and not as a death sentence. Hi, I'm Dr. Gary Kaplan. I'm Medical Director of the Kaplan Center for Integrative Medicine in McLean, Virginia. We've been here for about 40 years. I'm also a clinical associate professor over at Georgetown University School of Medicine. We've been treating people with some really complex chronic illnesses for a long time around here, mostly neuroinflammatory diseases. And so we treat people who suffer with myalgic encephalomyelitis, chronic fatigue syndrome. We treat people suffering with long COVID, people suffering with post-treatment Lyme syndrome, tick-borne diseases, and pandas. And in particular, we've also been working on people with Alzheimer's, because Alzheimer's is a neuroinflammatory disease. So what all these diseases have in common is there's a problem with their immune systems, and there's a problem with inflammation that's occurring in the brain. So what I want to talk about today is Alzheimer's. So Alzheimer's is a big problem. It affects over 7 million people in the United States alone and about 55 million people worldwide. Unfortunately, it affects women more commonly than it affects men by a ratio of about 2/3. It also is unfortunately more prominent in the African American community and in the Latino communities. So it's a big problem. It affects a large number of people across the spectrum, and we are just at the beginnings of becoming able to actually do something about this disease. So that's what makes it particularly interesting to talk about and particularly interesting to focus on now. Alzheimer's, unfortunately, is also a disease that's very personal for me. My mother died from Alzheimer's, and unfortunately, my wife is suffering with Alzheimer's. I'm real anxious to see what I can do in order to find a cure and what we can do in terms of being able to help people such as yourself not get Alzheimer's, because that's actually the headline. The headline is, it looks like there's about a 10 to 15 year window prior to the onset of Alzheimer's where we can pick up the beginnings of Alzheimer's and intervene in such a way that you ultimately won't get the disease. So that's the exciting news, in addition to some stuff we'll talk about in terms of what we can do for treatment of the disease now. I want to make some definitions first so we're really clear. So we've got this symptomatic cognitive stuff where people are going, I can't quite remember a word, as I just did, in this moment. And so if you do the testing, fortunately for me, my testing comes out pretty well. And so there's a number of memory tests that we can do to assess whether or not you're actually starting to have problems with your memory and your executive functioning and other day-to-day activities. So early cognitive decline is where you actually are forgetting important dates, you're forgetting names of people, you're forgetting not just where you left your keys, because you may have been doing that for a long time prior to that happening, but you're forgetting where you left your car. Over time, starting to have to cover up for more and more things. The first thing we want to be doing is cognitive testing, and that's easy enough to do in-office test or an online test in some cases that may cause you some concern. Alzheimer's disease is kind of the next step in that, and there we're seeing significantly more decline in function. You're having increased problems with not just word finding, but you're having problems with activities of daily living. You're having problems remembering the sequence of order in order to cook a meal, having problems with directions and getting lost when you're driving. You're having problems not just with names, but with names of people who should be familiar to you, your children, nieces, nephews, sisters, brothers, and perhaps your spouse. We want to be able to be clear about where you're on that spectrum, because that's going to change our intervention in terms of what we're doing. In your 60s is where we start seeing these little slips going on. Early on, the problem may simply be lifestyle. So if you're not getting enough sleep, how much sleep? You should be getting 7 to 8 hours of good solid sleep a night. If you have sleep apnea, that's going to create a significant problem. What's sleep apnea? Affects about 5% of the population. You stop breathing in the middle of the night multiple times. Snoring may be one sign of it, but also waking up with unrefreshed sleep. So sleeping problems can be a very significant issue, and we want to make sure that you're getting a good night's sleep. Other issues can be nutritional deficiencies, B12, in particular if you have something of undiagnosed pernicious anemia, if you have celiac disease. Celiac disease is where you have not just gluten intolerance, but you actually have an autoimmune disease. Gluten is the stuff found in wheat. and other bread-like products. The interesting thing is, we used to think celiac disease was a disease only of kids. The oldest person I personally have diagnosed celiac disease on, it was a 66-year-old male. Treating that fixed a whole bunch of problems for him. So we want to be looking at metabolic stuff. We want to make sure if you have diabetes that it's well controlled. We want to make sure if you have hypertension that it's well controlled. We want to make sure you're exercising. Exercise is extremely important in terms of reducing inflammation in the body and keeping yourself healthy. So there's lots you can do in order to be able to protect your brain and keep yourself healthy. The other big thing, and the single most important thing with regards to longevity, is having a big social network, close friends, being interactive with lots of other people. This actually has more impact than anything else that we can do in terms of our health span. So staying active, staying in community is extremely important for your overall health. So those are the things to take care of, the easy pieces, if you will. Then we start getting into a little bit more complex. If we're getting problems with early cognitive decline, and that we're measuring by a MoCA test, the McGill test, there's a number of tests that we can use, simple testing, pencil and paper, or on the computer. And we can do that testing and determine whether or not there are scores that start telling us where our breakpoints are for diagnosing early cognitive decline versus Alzheimer's. Alzheimer's is a disease where things have progressed to the point where, as I told you earlier, now serious memory problems are starting to show up. Issues with executive functioning as well as issues with truly being able to remember things. But it can also show up with depression and anxiety disorders. People who have depression lifelong tend to have a higher risk for developing Alzheimer's, but interestingly, new onset depression, new onset anxiety disorders may be the first symptoms of development of cognitive decline in Alzheimer's, because this is a brain that is inflamed. Now, the model in Alzheimer's to date has been focused more on amyloid. Okay, amyloid is the plaque that builds up, but we know there are other things that we can check for, tau tangles, and we do this in blood work, we can do it in the cerebral spinal fluid, and we can do it by PET scans. So there's a lot of ways that we can actually now diagnose the disease. But I want to back up because there are things we can do way before we get to the disease. So the things we can do before we get to the disease is a test called NeuroAge. NeuroAge is actually a big metabolic test. It's a blood test that we do. It looks at your genetics, but it also has some cognitive testing online associated with it. And in the more advanced forms of the testing, we actually do an MRI of your brain so we can measure the volume, the size of your brain. NeuroAge is a very interesting test because now it allows us to see how old your brain is compared to you. One of the things people miss on health span is that the body doesn't age uniformly. So the heart may be aging faster than the brain is, or the liver may be aging faster than the small intestines are. And so we need to be able to look across the board and see what's going on. Brain age, NeuroAge is very specifically focused on a whole bunch of metabolic factors that specifically affect the brain and things that we can do in order to intervene and help you. The other things that we want to look at is if you're starting to see potential evidence or you're concerned about the risk of this, we want to look for other things that cause inflammation in your brain. What are those things? Heavy metals, mercury, lead. Where are we getting mercury from? Fish. I have cured more cases of mercury toxicity simply having people stop eating fish for 3 months than having to do any chelation. So our diets become extremely important. Where are we getting lead poisoning from? The tap water. About 20% of the water supply in this country is contaminated with lead. So we want to be able to test for heavy metals. We want to be able to test for mold toxicity, all right? Mold toxins are the toxins that are produced by mold in the environment. Indoor mold is really what we're concerned about. And about 20% of the population doesn't make the genes necessary to make the enzymes to metabolize the mold toxins. And so what happens is they accumulate in your body, and they are neurotoxins and they are immunotoxins. So if you've got mold toxicity, we want to make sure that we're addressing that as well. First and foremost, test the environment you're in and make sure that you're not getting contaminated on an ongoing basis. So lots of things we can do, exercise, of course, being one of them, but we also want to optimize cardiovascular health. All right, and there's lots of early testing we can do to check for how healthy your heart is. It's not just about cholesterol anymore. Now it's about being able to do coronary artery scans with a CT scan, all of about a 10-minute test that cost about $125 to be able to do. So these are all things that we can now look at, and we look at, again, inflammatory factors like C-reactive protein. There's a lot of things that we can look at and start to fine-tune your health and personalize your care so that you get optimal care and optimal health. So lots of things we can do before you develop the disease and hopefully prevent you from developing the disease. If, unfortunately, we have a problem where actually the disease has occurred, there are things now that we can do. There are anti-amyloid drugs that can be used. There are challenges with these drugs. These drugs do not cure the disease. What they do is they slow the progression of the disease, and if you look at the literature, they slow it probably about 18 to 30%. What does that mean in real terms? Maybe you get about 5 months to a year slower decline, but you're still declining, unfortunately. Also, these drugs can have some pretty nasty side effects. They're called ARIA, ARIA-H and ARIA-E. ARIA-H is hemorrhage, so bleeding that occurs in the brain, and ARIA-E is edema, where the brain swells. If this occurs, probably not going to be able to use the drugs, and hopefully it's minor side effects in terms of clinically what you look like, meaning that mild headache, maybe a little more anxiety, maybe a little bit worsening of your cognitive decline. But as you withdraw the drug and the brain has a chance to heal, you should get better. The other things that we can now use that are not officially approved FDA but have shown in studies to be effective is therapeutic plasma exchange. I'm especially excited about therapeutic plasma exchange because that has about a 50 to 80% slowing progression of the disease. And what's particularly interesting is it does so without causing ARIAs. So the side effect profile on this is very low, bleeding, some discomfort. It's a procedure you're going to have to pay for out of pocket because insurance company isn't going to cover it, but we're talking about your brain and your life. So what are you worth? Therapeutic plasma exchange, extremely effective. I've seen it work on my own wife. I've seen it work on other patients. So it's an important tool that we now have. Is it going to cure you? Unfortunately, no, but it can help. And it can help, I think, better than the anti-amyloid drugs. Other things that can help, there's a new drug called TB006. TB006 is an antigalactin. Its mechanism of action is completely different than the anti-amyloid drugs. As such, its side effect profile is much less than the anti-amyloid drugs. So it doesn't tend to produce the ARIAs. That drug is administered once a month. It is IV, so you have to come in and receive it if you qualify for it. You only qualify for it if you failed one of the other therapies, and of course, we have proof by laboratory testing that you have Alzheimer's disease. But this is a drug which is being tested not just in Alzheimer's, but in Parkinson's and a number of other forms of dementia. And I want to step aside for a second and remind you that dementia is not a single thing. There's a lot of different types of dementia. So you can have Lewy body disease, you can have small vessel disease, you can have problems with temporal parietal dementia, or dementia associated with Parkinson's. These are different diseases than Alzheimer's is, and as such require different treatments. Alzheimer's accounts about 60 to 70% of all of the cases of cognitive decline. So it's the majority, but testing has to be done and make sure we've got the right diagnosis. But with the right diagnosis, we can get increasingly targeted for the therapies that will benefit you the most. Another therapy which is beginning to show a great deal of promise is transcranial magnetic stimulation. We have not used that here in the clinic, but certainly I'm looking at the papers, and the papers look very promising and very exciting. It takes a number of treatments. They don't take long, but you have to be at a center where they're doing transcranial magnetic stim. Transcranial magnetic stim has been approved by the FDA for other therapies, such as depression, suicidality. It's a machine that's simply being repurposed, the therapy being repurposed, as is the therapeutic plasma exchange, that has FDA approval for other conditions to date. So there are things we can do. There are things we can help you with if, in fact, you're beginning to develop the disease. There are things we can do to slow the progression of the disease. So the bottom line is, if you're worried about it, get checked. We can help understand where you're at in terms of problems struggling with cognitive issues. We can also help you potentially reverse a great number of those issues. We just had a patient who had some positive blood markers and other issues associated with cognitive decline. My associate, Dr. Lisa, was treating them. She cleaned up their diet, she cleaned up their exercise, got them to lose weight, and all of those markers have gone away, and more importantly, the clinical signs, the memory issues he was complaining of, have also all resolved. So there's a lot that can be done to turn the clock back, if you will, and help you out. Tirzepatide looks like a potential drug. The weight loss drug looks like it's potential in terms of protecting the brain. And so using that early on may be something that we want to consider. Other considerations is Shingrix, all right, the shingles vaccine. Shingles vaccine looks like it's protective against development of Alzheimer's. Again, that's probably because there are bacteria and viruses that are associated with inflammation in the brain and cognitive decline. So getting Shingrix vaccines, highly recommended, may protect you from developing the disease. Lots that we can do to intervene early and prevent the onset of the disease, and things we can do to slow and potentially reverse the disease itself. More things are coming down the pike. There's a lot of reason for hope. And so it's a very exciting time. And I think within 5 years, we're going to have this as a chronic illness and not as a death sentence. Make sure we're really clear between Alzheimer's, dementia, and actually let's stage it a little bit differently. So you've got early memory complaints, right? Forgetting names, forgetting dates, but I mean, not big ones. And they come back to you, by the way. That's part of normal aging because the brain reprioritizes stuff. Subjectively, you start to worry about things, but the reality of the matter is, if we do testing on you, it's all going to be normal. So the neurocognitive testing will be normal. Your daily functioning, frankly, is completely unimpaired, and there's no brain pathology. Progression of risk? Perhaps. Again, I think it's worth asking because there may be other metabolic issues going on. Subjective cognitive decline, okay? Yeah, again, now we're seeing more problems that you're noticing and maybe other people notice. But the reality of the matter is day-to-day functioning is actually going extremely well. You may begin to see some early brain pathology, and this is, again, we want to take a look. Remember I said there's a 10 to 15 year window before the development of the disease. We want to take a look at your risk, and we want to take a look at your age. This is a place where we might want to be doing neuroage to really get a sense of how you're doing and be able to target our therapies. Looking at mild cognitive impairment, now we're further along the way, and other people, in addition to you, notice a problem. You may have more memory complaints. You may have more problems with finding things, remembering big dates, and your day-to-day activities can be a bit interfered with. Now we're going to do neuropsych testing on you. That's going to be abnormal. Now we're going to be doing other investigations on you. We're going to find them abnormal. And the risk of progression to true Alzheimer's is extremely high. Alzheimer's itself, now we've got much more severe cognitive daily activities being interfered with, right? You're forgetting the order in which to do things. You may be able to drive to a place, but you can't remember where you parked the car after you've gotten there. And so we're seeing progressive impairment in your ability to function day to day. Your anxiety may be higher, your depression may be worse. And again, if we're treating you as your depression is the problem and not Alzheimer's, we're doing the wrong thing. Because the problem is a neuroinflammatory disease. Your brain is inflamed, and there are things we can do to treat it. Now, I also want to tell you that we've had patients come in who were diagnosed with early Alzheimer's disease, and in fact, they had Bartonella infections. So we want to be testing for tick-borne infections and other potential infections that may be creating inflammation in the central nervous system. And doing so, I believe Chris Christopherson at one point was diagnosed with Alzheimer's and in fact had Lyme disease. And when Lyme was treated, his memory recovered. So we want to be attentive to that. We want to talk about COVID. COVID is what tripped off my wife's Alzheimer's, made her dramatically more depressed, dramatically more anxious, and progressed thereafter. And it wasn't recognized that that was the disease originally. We just thought that she had brain inflammation secondary to COVID. Actually, COVID was the straw that broke the camel's back that finally tripped her off into developing Alzheimer's. This is a disease that's been simmering underneath her brain all of this time. That infection probably brought it to the forefront. The other thing is there's some very interesting data showing that the brain changes associated with COVID are very similar to the brain changes associated with Alzheimer's. So getting vaccinated, treating COVID if you have it. If you've got an upper respiratory infection, test for COVID. It's not a big deal because there are things we can do that will slow or stop the disease itself, and doing things such as 10 days of metformin in addition to Paxlovid may actually prevent by 85% the occurrence of post-COVID syndrome. So we want you paying attention, and we want to get as specific as possible as to what diseases you have and what we can do in order to be able to help you recover. Now, what we didn't address was talking about long-term effects as Alzheimer's is progressing. The number one, number two, and number three priorities are safety. We have to make sure that our loved one who has Alzheimer's is safe, that they're safe around the house, that they're safe in driving. And so these are hard conversations and these are hard decisions to come to. But you want to be as honest and direct as possible, because otherwise, if you're sweeping it under the rug, somebody's going to get hurt. We hear these stories of an older individual driving down the sidewalk and killing somebody. Bad enough if they get injured in the car. It's horrific if they kill somebody else. So we want to make sure that they are safe and that makes sure that everybody else is safe. So we want to make sure that they have the support around them. And there are easy things you can do. We have someone coming into our house several days a week that helps my wife with organization. My wife has a schedule in terms of where she's supposed to be and what she's doing during the day. And we make sure exercise is part of that regime. So there are a lot of things that you can do helping the person stay safe at home and allow them to remain at home for extended periods of time. So this is a disease which is complicated. This is a disease which requires a great deal of compassion and patience. It is one which needs to be faced with great courage because it's terrifying to the individual and it's pretty damn rough on all their loved ones around them. So we can do things earlier, we can do things before the disease develops, we can do things as the disease is developing, and we can do things once the disease has set in that keeps everybody sane and healthy. It's hard, but we can help. The other thing I want to address briefly is testing for Alzheimer's. So there's neuropsych testing that can be done, certainly. There's testing that can be done, as we talked about, neuroage, to be able to get a very in-depth understanding as to what's going on with the metabolism of your brain and help us direct therapies. But there's also blood tests. Now, the blood tests have become a bit controversial. We had hoped at one point that they were going to be the answer in terms of easy office diagnosis. I think they're useful to us, but I think that we've still got a bit of a challenge in terms of integrating that testing into our exams. Cerebral spinal fluid testing, no question, that'll actually give us the data that we need in order to help make the diagnosis. PET scanning, much more elaborate, much more involved in terms of testing, but that can measure the amount of amyloid in your brain. Also genetic testing, so ApoEs. The ApoEs, there's two SNPs, and they are 4443, 3222, and basically the lower the numbers, the less the risk, but it also helps stratify the treatment that we can do for you. So an ApoE44, unfortunately, has a much higher risk in terms of developing the ARIAs we talked about earlier with the anti-amyloid drugs. There are also genetic SNPs that we can look at when we're considering TB006 for people that'll help us understand whether or not the drug will work well for you, whether or not the drug will have an average effect for you, or whether or not the drug actually may not be appropriate for you. So we're starting to incorporate more and more genetic testing in order to help us understand how to direct therapies and fine-tune therapies that are best for you. There's one other test that is not yet approved, but is showing some really incredible promise. It's a device called BrainScope. BrainScope is an electroencephalogram-based device. Basically, it's a helmet you put on your head. And recently in Nature, about 2 months ago, an article came out demonstrating proof of concept that BrainScope was able to diagnose Alzheimer's 5 to 7 years prior to the onset of clinical symptoms. So it's an extremely promising technology, not yet approved, but it's coming fast, and the data is growing increasingly impressive on it.